we have this for future reference, of course. Welcome to our third session of the ACC Fit Bootcamp, a survival guide for the first-year fellow. Today we'll be going over Cath basics, and as a reminder, these sessions are every Wednesday at 5 p.m., so please feel free to join us. Additionally, if you've missed the two beforehand or you want to rewatch this again, they're also available on the ACC website as well as the YouTube channel.
All right, so we're going to just jump right into the third session. It's going to be by Dr. Jason Hoff. He is from Loma Linda. So a quick intro on Dr. Hoff. He is an early career interventional cardiologist. He's at Loma Linda University Medical Center. He is also an associate program director for the Cardiology Fellowship Award. He completed his internal medicine residency at Baylor College of Medicine in Houston, Texas. Then he moved to California to complete his general cardiology and interventional cardiology fellowships at Loma Linda University. And that's when he stayed on as faculty. During his fellowship, he was awarded the Excellence in Cardiology Fellowship Award by the California chapter of ACC. And he is driven by his love for medical education. He enjoys bedside teaching. He provides lectures for the fellows, residents, and med students. And outside of the hospital, he is married and has 4 young kids and a set of twins. And he says that his hobbies include piano, snowboarding, fitness, and his personal favorite, barefoot water skiing. So a lot about Dr. Hoffman. So we're going to go ahead and play. So he's going to be talking about Cath basics. All right, let's do screen share right here. So just a reminder, so right after this lecture, we're going to do a live Q&A with Dr. Hoff. During the lecture itself, please feel free to you can send privately your questions to myself and Megan, so that way we can ask for you. And if you could please keep yourself muted during the session. But yes, please do chat us with your questions, okay? So we can run those to Dr. Hoff during the live Q&A. All right, thanks so much.
Fantastic. So we'll get started. Let us know if you're having any technical issues, if you can't hear us.
Hello and welcome to another lecture in the Cardiology Fellow Bootcamp series brought to you by the California chapter of the American College of Cardiology. My name is Jason Hoff and I'm an early career interventional cardiologist and associate program director for the General Cardiology Fellowship at Loma Linda University here in Loma Linda, California. So I'm excited to provide incoming cardiology fellows with an introduction to the catheterization laboratory.
We looked at his coronary. This
I have
was
no
just like
disclosure.
some
Yeah, I think it was
mid-
non-obstructive.
Yeah.
Our learning objectives are as follows: to provide incoming first-year cardiology fellows an introduction to the Cath lab, help them understand the basics of the pre-procedural assessment, learn the basics of safe femoral and radial artery access, learn the coronary anatomy visualized on basic Cath lab views, learn how to obtain manual hemostasis post-procedure, and review tips for success for incoming fellows in the Cath lab. So I know the majority of you can't wait to get your hands on the equipment and start learning how to perform complex diagnostic and interventional procedures in the Cath lab, but we need to go over a vital part of any Cath lab procedure, and that's the pre-procedural assessment. So I can't stress this enough. You need to know your patient. We are not just proceduralists, we are doctors first. I had a respectable interventional cardiologist tell me in training that you could teach a monkey to do an angiogram, making the point that the most valuable thing that we can provide is knowing when and why to perform a procedure, as well as when not to perform the procedure, more so than even how to perform it. In that mindset, yeah, we must absolutely know our patient before bringing them down to the Cath lab. So like I said here, it's the most important part of any procedure. Before the start of any procedure, you need to go and thoroughly assess the patient, go over the risks and benefits of the procedure, review for any potential contraindications, which we'll go over, obtain informed consent, and then address any pre-procedure orders and medications, and prepare an overall diagnostic and treatment plan even before the patient gets to the room. Here are the relative contraindications to doing a diagnostic coronary angiogram on a patient. So if someone has acute gastrointestinal bleeding or worsening anemia, therapeutic anticoagulated, have a severe electrolyte imbalance, especially hypo and hyperkalemia, active infection and fever, medication intoxication, pregnancy, recent stroke less than a month ago, new or worsening renal failure, uncontrolled congestive heart failure, high blood pressure, and uncontrolled arrhythmias, or an uncooperative patient who won't stay still on the table. Consent before the procedure should be obtained by the operator or the attending or fellow involved in the procedure unless an emergency situation does not allow this to be facilitated. This is the operator's chance to build rapport with the patient and the family, as well as answer questions and potentially alleviate stress for the patient. So what you want to do is you want to describe in simple terms what procedure will be performed, explain the reason for performing the procedure, as well as potential outcomes. If intervention or stenting is possible, this needs to be consented for at that time, and describe different treatment options such as medical management, stenting, or CABG as a potential option. Walk the patient through what they can expect during the procedure and the roles of the various team members. Explain the risks or potential complications of the procedure, which we'll go over. Always try to include family members in the discussion because that's very well received, and more brains are always better than one. And after you're done doing all this, it's important to have the patient repeat back to you in their own words their understanding of what was discussed. And this is especially important when consenting patients who have questionable capacity to consent, have them repeat back to you. For diagnostic catheterization, an analysis of the complications in more than 200,000 patients indicated the incidence of risks, and that included approximately 0.2% risk of death, 0.05% risk of MI, 0.07% risk of stroke, 0.5% risk of ventricular tachycardia, fibrillation, or serious arrhythmia, and more commonly, about a 1% risk of vascular injury, pseudoaneurysm. So, going over these with the patient, doing so in layman's terms, while the risks are low, it's not zero risk, and they need to understand that. This is a list of things that make patients potentially higher risks to bring down to the cath lab. One is acute MI, advanced age over 75 years, aortic aneurysm, aortic stenosis, CHF, diabetes, extensive 3-vessel coronary artery disease, LV ejection fraction of less than 35%, obesity, prior stroke, renal insufficiency, suspected or known left main coronary stenosis, uncontrolled hypertension or unstable angina. And as you can imagine, the vast majority of patients you will treat in the cath lab will actually have several of these when you go from case to case. So in summary, here's a non-comprehensive summary of things to consider and review prior to bringing the patient down to the cath lab. So you want to go over their history, the reason for the procedure, potential contraindications for the procedure, and you want to do a physical exam, paying particular detail to the plan for access. Can the patient lay flat for the procedure? Is the patient hemodynamically stable to bring down to the lab? You want to look at their most recent or several of the most recent electrocardiograms. You want to look at any prior angiograms, especially most recent angiogram, echocardiogram, and non-invasive imaging like stress tests or coronary CT. Looking at their labs like their electrolytes, like I said, particularly hypo and hyperkalemia. Look at their creatinine or kidney function, seeing if their creatinine is uptrending or worsening compared to baseline. And if so, going over with the patient if it's an urgent or emergent procedure, the potential risk of worsening renal function and even need for dialysis with the procedure may be prudent to do before bringing the patient down to the lab. Looking at their hemoglobin, assessing for worsening anemia or potential occult bleed. Looking at their platelets, reviewing their anticoagulation status if they're on Coumadin, looking at their INR. Otherwise, looking at the last dose of their blood thinner like Eliquis or Xarelto. And then doing your pre-conscious sedation assessment And every institution that you will train at will assess or do a pre-test to teach you the pre-conscious sedation assessment. So now we've arrived to the promised land, the cath lab. Like everything in medicine, the best rule of thumb is to behave like you are treating a loved one. Thus, there are certain expectations in terms of etiquette and professionalism that are expected by all team members in the cath lab, as we are commonly dealing with life and death situations. So at all times, you want to be professional and courteous to create atmosphere, and that should be upheld at all times. You want to talk in calm and quiet and straightforward communication related to the case only, and avoid extraneous conversations. All team members should be locked in and focused on the case. When you talk to the patient, you want to give clear communication and instructions, and a lot of times use their first name to get their attention. Everyone involved is responsible for the patient's safety, and so everyone should be doing what they need to do during the procedure, but also paying attention to the patient's hemodynamics. And so it's not just up to the attending to notice when the blood pressure is going down. The first person that can notice it could be the nurse, the rad tech, the fellow, really anybody, because everyone's actively monitoring the patient's situation and monitor the patient's EKG, hemodynamics, and clinical status. You want to avoid an assembly line or factory mentality. It's like, oh, it's another heart cath coming down, it's another PCI. No, each case is unique, a unique person, someone's loved one, and you want to take each case seriously. Now on to a brief review of some of the cath lab equipment. So this is a picture depicting a cath lab with different numbers of the different items. I'll go over just some of them here. So number one is the CMR, the fluoroscopy unit. Number two is the fluoroscope X-ray generator. So that's where the X-ray is generated. And then the number three is the image intensifier. Number four is the patient's table. 8 fluoro pedals on the floor. Number 6 is the monitors that will show the fluoroscopy images, hemodynamics of the patient, and anything else that you're doing, potentially intravascular ultrasound, OCT, FFR, IFR, can all be put onto that screen so you can see it while you're doing the procedure. And then number 9 is the control room monitoring screens, which are typically, not typically, they're behind lead glass, but this is just a picture showing what they look like. So here's a picture of the pressure manifold used in coronary angiography. Starting from left to right on the manifold, which you can see is labeled there on that top picture. So the tubing, the end attachment there is the tubing that connects to the coronary catheter, okay? And then moving over, the first stopcock from left to right is to the pressure transducer to measure your hemodynamic pressures. And that tubing, which is shown, the transducer tubing in that picture on the top left, goes to the actual transducer, which is in that picture on the top right, okay? And that's, so it shows 3 different potential transducers there. The second stopcock connects to your saline flush and waistline. So when you draw back the syringe with this stopcock open, it'll pull saline flush that you can use to flush your coronary catheter. And then if you inject into this line with it open, it goes through a one-way valve to the waistline. Okay, so that's where you can dump blood or potentially contrast if you're not using it. And then the third stopcock is to contrast. So when you're starting out as first-year fellows, I highly recommend you scrub in with the rad techs when they're setting up the table at the beginning of the case. And they can walk you through setting this manifold up, which will make using it during the procedure make more sense because you set it up yourself, and that will make you look better in front of your attending. So many centers are using the assist pressure injector, and so that might be something you also see at your center. So moving on to access. So in terms of one of the most technical aspects of any catheterization procedure, it's going to be obtaining vascular access. Vascular access sites complication, like we talked about, are the most common cause of procedure-related morbidity in patients undergoing diagnostic left heart cath and percutaneous coronary intervention. Even though providers prefer radial access now over femoral for most cases, understanding obtaining safe femoral access and management of its complications is essential for any cardiologist, interventional cardiologist doing procedures. And I understand you're going to be having another lecture here going over all those potential complications and management in another session here. In large bore access, such as used in TAVR and Impella, vascular complications are more frequent, getting larger bore and associated with increased mortality. Ultrasound guided access is the cornerstone for getting safe access, whether radial, femoral, internal jugular, wherever you want to get access, you're going to want to use ultrasound. The two landmark trials for the use of ultrasound access for femoral and radial artery access are the FAUST and ROUST trials, respectively. That stands for real-time ultrasound guidance, facilitates femoral artery access and reducing vascular complications. FAUST, femoral artery access with ultrasound trial. This demonstrated that the routine real-time ultrasound guidance for access reduced the number of attempts, time to access, risk of venipunctures, especially in femoral access, and then vascular complications, which was more in the femoral over radial, but still. And so overall, it's a no-brainer to use ultrasound for your access. This is the access equipment. So in the middle there, you have your perc needle, and then all the way on the right, you've got your sheath and the wire right there. And then for radial access, you have a potential cocktail, which could include heparin, ecardipine, nitro, and medications to prevent radial artery spasm. And then you'll definitely want to use lidocaine there on the far left to anesthetize your skin prior to getting access. We'll start with femoral because that was the traditional way people did access for their procedures. So for safe femoral access, the best fluoroscopic landmark for the CFA puncture is midway between the center and most inferior border of the femoral head. This location offers the best chance of being below the inguinal ligament, the inferior epigastric artery, and above the femoral bifurcation, which is where you want to be. Okay. Complications are reduced with ultrasound-guided arterial puncture, like we talked about, with the summary in terms of reduced number of attempts, improved first pass success rate, and then reduced complications as well, like we talked about. So we're going to go through step by step how to get safe femoral access every time. Okay. So first and foremost, before ultrasound access was routinely used for access. Access was obtained using only anatomical landmarks. So if you mentally or physically draw a line from the anterior superior iliac spine to the symphysis pubis, that'd be where the inguinal ligament is, and that's where you'd not want your access to be above, because you get increased risk of retroperitoneal bleed. The optimal location for access in the CFA over the femoral head, below the lower course of the inferior epigastric artery, and above the bifurcation of the superficial femoral artery and profundus femoris, as you can see there in the picture. Now, having said that, many of us, if not most of our patients, are obese, which makes for identifying superficial landmarks next to impossible in some cases. Luckily, now we have a better way of getting access. So first and foremost, I like to use pickups or another metal instrument to identify and mark the femoral head location under fluoro. Okay, so you put that on the patient's skin approximately, where the access is going to be. Now you can move it up or down once you get under fluoro. Now in this particular picture, you can collimate or narrow that window a whole lot more. You really only need to see the femoral head for this. Okay. But this allows you, some people put that in the middle of the femoral head, Some people put it at the bottom of the femoral head, whatever works better for you, but just so you get a sense of, okay, here's where the access needs to be, and kind of guides so you avoid the high stick. Next, you're going to use ultrasound to identify the bifurcation. So you have you mark where you put where the femoral head is, and you put the ultrasound there. You basically scan down toward the feet until you see the bifurcation from the CFA to the superficial femoral artery and profundum femoris, so you can see on the left picture. And then next to it, you see the femoral vein. Okay. Once you find that, you can either use a marker to mark that location or just mentally know where that bifurcation is, and then scan back up until you get to where the CFA is. And then you can use your other landmarks so you know where the lower border of where you need to stick is and the upper border of where you need to stick. So now you know exactly where you need to go to get perfect access. So after you anesthetize the skin, and in general, most people are too quick with their local anesthetic. So you want to give a good amount of lidocaine. You start by anesthetizing the very superficial skin. Let that sit for a second. You can even massage it in gently. And then do deep lidocaine administration down to the artery. Give that a second to kick in. Test it with the needle, asking if the patient can feel anything sharp or just pressure. Once they're properly anesthetized, then go with your perc needle to try and gain access to the artery. Okay. So you have your low landmark and you have your upper landmark. And so then you have you follow the needle tip down from the skin down to the artery until you're just above the artery, even tenting the artery. And then before you stick the artery, what you should do is stop, go back under fluoro, tap on fluoro. Just make sure you're happy with the location of where the stick is going to be before you stick the artery. Okay, and it should be right in the middle of the femoral head or in the lower third, okay, depending on where the bifurcation is. Okay, then you get access. In this particular case, they were using the micropuncture kit. So basically it's a smaller percutaneous needle, and then you place a very small sheath into the artery, just big enough to allow for a picture like this. And then if you like it where the stick is, then you put the regular guide wire in and put the normal sheath in over that. The benefits of this, especially for people who are in training like fellows, it allows for, if you don't like where the stick is, you can hold pressure for a short amount of time and then go in and get it exactly where it needs to be. This is also very useful in large bore access, which is when you're putting in the Impella left ventricular assist device or doing TAVRs, where getting perfect access location is of the utmost importance, that you can restick very easily if needed. So that was used in this particular case. Okay. All right, so you've got good femoral access. If you do those steps every time, you'll have no problem getting the access where you need to be. Okay, so moving on to radial access, which at least in our center, the vast majority of access for diagnostic angiograms. Okay, so going through step by step for radial access, same thing, you're going to first identify superficial landmarks and palpate the radial pulse and find the best place to stick the artery. Next, you're going to use your ultrasound to find the radial artery. And this allows you also to assess if there's the pulse is not very palpable, to see if the size of the artery is allows to do access through the radial artery, and kind of make the decision before you start poking. So you can transition to femoral access if it's the artery is non-existent. Okay, so you can see there, RA, that's the radial artery. Same kind of thing, you're going to anesthetize the skin. It's a lot more shallow for radial artery access. So you just need to give a little bit of local anesthetic just under the skin. And then you're going to access the radial artery under ultrasound. You see in this particular view, you have the ultrasound and perc needle going in. You can see at 12 o'clock the tenting of the radial artery compared to the prior picture. So this person knows that when they stick the artery, they're going to be perfectly at 12 o'clock and it's going to be good access. Once you get bleed back to the needle, you're going to advance the wire through the needle, remove the needle with the wire in place, advance the sheath over the guide wire, and then remove the wire and dilator. You're going to aspirate and flush and administer your radial medication cocktail to prevent vasospasm and to thin the blood with heparin. Okay. So you've gotten your excellent, perfect access, and you're ready to start taking some pictures. So for the first year fellows, learning and interpreting the anatomy on a coronary angiogram is one of the first big hurdles for first years. And so starting now and getting a head start like you guys are doing it is a good job, because it's something that they'll get asked about a ton until you learn it. So engagement of the left and right coronary arteries is performed in the left anterior oblique view. Okay, so with the image intensifier over tilted towards the patient's left side. And then the most common views that are performed for a diagnostic angiogram includes elaiocaudal, ariocaudal, ariocranial, and elaio-cranial. And we'll go through all four of those here. So ariocaudal is when the image intensifier is towards the patient's lower right side, as seen in the picture right there. The ariocaudal shows the left main coronary artery bifurcation perpendicular to the elaio-cranial view. The origin and course of the circumflex and ulnar branches are clearly seen, as well as the ramus intermedius, if it's present, and proximal LAD is well seen in this view. This and the elaiocaudal are the two best views for visualizing the circumflex artery as well as its branches. As you can see clearly in this, the LCX, or left circumflex, comes down the screen with the ulnar branches laying out perfectly like that. So really good for assessing the circ. Moving to the other caudal view, the LAO-caudal, or spider view as it's commonly known as. The elaiocaudal is when that image intensifier is towards the patient's lower left side, as seen in that picture. The elaiocaudal view shows the left main coronary artery as well. It is slightly foreshortened in the bifurcation into the LAD and circumflex arteries. So it's great for looking at the bifurcation. And so if people are doing bifurcation stenting of the left main coronary artery, this is a view you work out of a lot of. There's good visualization of the proximal and mid portions of the left circumflex, as well as the ulnar branches. The LAD is very foreshortened, as you can see in this view. It can be difficult to get good separation of the vessels, especially someone with a very vertically displaced heart, such as in COPD. You see, you need to do a very steep elaiocaudal in those patients to allow for opening up that bifurcation. Moving on to the cranial views. This is the RAO cranial view, and that's when the image intensifier is towards the patient's upper right side, as seen in that picture. This view lays out the mid to distal LAD very well, and is used to look at the origins of the diagonal branches. Okay, the proximal LAD and circumflex are usually overlapped, as you can see in the picture there. Ulnar branches can also overlap. The circumflex is foreshortened, but if you've got a left dominant system and you've got a left posterior lateral branch off the circumflex, that can be well visualized in this view. And lastly, the LAO cranial view is when the image intensifier is towards the patient's upper left side. It shows a slightly foreshortened left main coronary artery, but it is good at visualizing ostial left main lesions. Shows LAD going straight down the pipe and down the middle with septal perforators coursing to the left and diagonal branches to the right of the LAD. Left circumflex and obtuse marginal branches are foreshortened and overlapped. Although the same as the other cranial view, if you've got a left dominant system and you've got left posterior lateral arteries as well as left posterior descending artery coming off the circumflex, it can be displayed very clearly in this view. In fact, I had an intervention last week, and this view was perfect for that. A deep breath in this cranial view can be helpful to move the diaphragm down and out of the way to allow for better angiography of the vessel. In all of your diagnostic angiograms, strive to always provide the highest quality angiogram you can in order to make the best diagnostic and therapeutic decisions for the patient. Some tips to achieve this are as follows. So you want to ensure the table is positioned before you do your cine angiography so that minimal to no panning of the table is necessary. You want to collimate the view as much as possible without having to pan to get the whole anatomy into it. You want to decrease the height of the image intensifier over the patient. You want to ensure adequate engagement of the catheter so it doesn't blow out when you try to inject. And then you want to inject enough contrast and flow to allow for full opacification of the vessel to avoid streaming. Because if you've got streaming and poor injection of the artery, it can be really hard to assess some intermediate lesions because it can look worse with streaming than it actually is. And you want to take enough pictures and views to get the information you need. So if you do the initial 4 pictures and there's a question, you may need to take modified views like an AP cranial view, so just straight up towards the head. Cowboy view is what's another, or AP caudal, to kind of try to slightly get a better view of what you're trying to look for. So now we're going to the basics of coronary catheters. So this is a Judkins left on the right side there and a Judkins right, and we'll go through all the catheters here in a second, not all of them, but all the common catheters. And so all the catheters have primary curves and secondary curves, as you can see there, and just has to do with the distance from the actual tip. So the first curve there and the second curve there. And the sizing of the catheters has to do with those curves a lot of the time. So we'll go through these here. This is kind of a summary slide to show a lot of the common catheters that you will use in typical day-to-day diagnostic angiograms. So the Tiger and Jackie catheters are both called radial universal catheters because they're used from the radial approach, and they can engage both the left and right coronary ostia with one catheter without having to switch it. And the benefits of using a universal catheter from the radial approach especially is that you reduce catheter exchanges and therefore reduce potential for radial artery spasm, because anytime you take a catheter out, put a catheter in, or prolonged manipulation, you increase the risk of having radial artery spasm, which causes increased pain for the patient and increases or decreases the ability to manipulate the catheter to get it properly engaged. The Amplatz catheters have a pre-shaped half circle with a tapered tip extending perpendicular to the curve. They come in Amplatz left, 1, 2, and 3, and an Amplatz right, 1 and 2, with that number indicating the diameter of the tip curve. Most commonly used is the AL2 for the left and the AR1 for the right. The left and right coronary bypass catheters, or LCB and RCB, are used for bypass angiography, as the name implies, to help better engage the vein grafts to the left and right coronaries. So the Judkins catheters derive their name from Dr. Melvin Judkins, who initially performed the femoral artery catheterization technique. They have a pre-shaped curve as shown above. The JL, or Judkins left, coronary catheter has a double curve, and the length of the segment between the primary and secondary curves determines the size of the catheter. So it comes in a 3.5, 4, 5, and 6 centimeter. And that, like I said, that number correlates with the distance of that segment between the primary and secondary curve. The standard JL size for femoral access is typically a JL4, and for radial, typically a JL3-5, but you may need to adjust depending on the length and width of the ascending aorta. For example, a very small person and a small aorta, a 3-5, Judkins 3-5, JL3-5 is appropriate. Whereas a large person or someone with enlarged or dilated aorta, you may need to increase that to a 5 or even a 6 centimeter, so JL5 or 6. The JL catheter was very well designed and typically engages the left main ostia without much manipulation, And to quote Dr. Judkins, he would say, the catheter knows where to go if not thwarted by the operator. And actually, Dr. Judkins worked here at Loma Linda for many years, and our fellows room here is actually named in his honor. The JR catheter is sized by the length of the secondary curve and is available in a 3, 5, 4, and 5 centimeter sizes, but most commonly used as a JR4. Multi-purpose catheters are those with a mostly straight or slightly angled shape, as you can see there. It can be used to engage both the right and left coronaries, as well as the vein grafts, particularly vein grafts that come off in a downward trajectory, or a right coronary that comes off very downward. That's very useful for that. And also sometimes can be used for very high takeoff or upward facing left coronary that comes off. And then the internal mammary artery graft catheters have a sharp hook that facilitates engagement of the internal mammary artery grafts, especially when they have a vertical origin of the internal mammary artery. Okay, so you're taking your pictures, you've gotten high quality images, good access. Now it's time to get hemostasis after the procedure. So for radial artery access, that's obtained with what's called a TR band, which basically is just a band that provides pressure over the radial artery and basically holds pressure for you. So most of the time, in terms of manual hemostasis or manual pressure, that's done when you do femoral access. And this is, very extremely important to know how to do adequate manual pressure. We'll kind of go through that here. Essential principle for obtaining hemostasis is that careful preparation and meticulous technique may prevent the majority of the complications you might see. Proceeding carefully and correctly during the first attempt may save you hours of effort from a failed attempt at hemostasis. And if you have someone who has failed hemostasis and they develop a large hematoma, trying to get hemostasis at that point by putting pressure is going to be very uncomfortable for the patient and very difficult for you, and may develop a vasovagal reaction and be very stressful for both parties. Before moving the sheath, ensure patient is comfortable with adequate IV access. You want to do frequent vital signs, have pain meds given if it's a painful groin, have the patient void before starting if possible, have atropine and IV fluids immediately available in case of a vasovagal reaction. Blood pressure should be controlled because if the patient is severely hypertensive, that may interfere with the ability to achieve hemostasis. Ideally, you'd like the ACT less than 150 milliseconds. The patient removing the sheath should also be comfortable and be in an ergonomically advantageous position so they can provide a good manual pressure. Compression should be performed using the fingertips rather than a fist or a wad of gauze tissue to focus on the site of the vascular entry. And you'll see this all the time when people who don't know how to hold adequate manual pressure, they'll get a big wad of gauze and just kind of put pressure, but that's not getting focused pressure over the artery where you're trying to get hemostasis. And so if you come to the bedside where someone's doing failed manual pressure and everyone's getting very stressed, you walk up, I would take that gauze away, see where the bleeding is coming from, and you get a lot of times 2, 3 fingers, hard pressure in the right spot, and you can stop the bleeding and obtain hemostasis. Okay, so avoid the wad of gauze if possible. The duration of the compression is variable depending on the sheath size, anticoagulation, body habitus, ease of compression at the site, degree of vessel calcification, and blood pressure. So all those things need to be taken into consideration. The more of those you have, the longer you want to hold pressure to get hemostasis. But the rule of thumb is at least holding double the French size. So for example, if you have a 5 French sheath and the femoral artery, you want to hold at least 10 minutes of manual pressure before checking to see if you got hemostasis. There are several closure devices on the market that you'll encounter during your training, which we won't go into in this talk, but I just wanted to kind of show you. Here we have a picture of the Angio-Seal, the PERT Close, ProGlide closure device, and the Minx closure device. These devices are extremely useful in assisting in achieving hemostasis and reducing bed rest time. However, manual pressure is a cornerstone of hemostasis. When a closure device fails and you're trying to remove an impella or large bore sheath, you need to know how to hold adequate manual pressure. We'll briefly cover some basic radiation safety because that's important anytime you step into a cath lab procedure. So in general, there's a couple overarching principles for radiation safety. The less the exposure, the less change there is of absorbed energy biological interaction. So no known level of ionizing radiation is a permissible dose of absolute safety. Radiation exposure is cumulative. There's no washout phenomenon. And it's the responsibility of all 10 team members in the cath lab to minimize and reduce risks to other personnel and themselves. Here are some ways to limit exposure to you during your training and beyond for radiation. You want to wear a lead apron, particularly a wraparound lead apron of 0.5 millimeters or more thickness, because that gives you 80% protection. You want to limit, when you're controlling the fluoro and cine, you want to limit the fluoroscopic and cine angiographic time, because that lowers the total radiation exposure. And so you want to use collimators, so you make the window in terms of what you want to see as focused as possible. Reduce the distance between the X-ray source and the patient. Maximize the distance between the X-ray source and the operators. Keep the magnification of the image as low as possible. Set up shots to obtain the highest quality images in the least amount of shots. Use extra shielding such as leaded thyroid guards, lead glasses, and protective table shields. And then you can also use radiation or rad pads to help block scatter radiation from the patient. Your institution will have you go through a radiation safety lecture prior to starting. And the state of California requires a fluoroscopy license for anyone planning on working in the cath lab. Here are the COCAT's training requirements. Just to briefly show you everything that we do in Cardiology Fellowship, you got to count your procedures. So every time you read an echo or do a diagnostic cath or get involved with an intervention, you want to record that in your notebook or Excel spreadsheet or however you want to do it. Because at the end of your training, this is how you get privileges. So here are the training requirements for level 1. Minimal number of procedures is 100 with 4 months of training. Level 2, you want to do minimal cumulative number of cases of 300 with 8 months of training. And then for interventional cath cardiology, you got to do this interventional cardiology year with 250 PCIs, total of 20 months of training. And so cumulative number total of cases is 550. So these are, I wrote down some tips for success that I thought about when I was in training as well as now that I've been on the other side of it. So number 1 is the most important thing to know about is your patient, like we discussed in the very beginning part of the lecture. You want to read up on the procedures prior to participating and never stop learning. So if you're doing a new procedure or even a new aspect of a procedure, if you're using intravascular ultrasound for the first time or fractional flow reserve or anything like that, you want to read up on it prior to doing the procedure because you'll get much more out of it than you would otherwise. Like I told you, assist rad techs with setting up the equipment, especially in the beginning, because that helps you learn more in terms of the equipment and the setup, and you'll just get more out of your month in the cath lab. When you actually have your hands on the catheter and the wire, never push the resistance. So I can't stress that enough, especially when you're early on, you don't know exactly what is normal and what to feel. If you feel resistance and you're unsure, never hesitate to ask the attending. They should be more than happy to feel to make sure it's safe, because in the end, all we care about is patient safety. Do not rush during the procedure. Just try to be as efficient as possible by anticipating the next step. That's the best way to be quicker. The more you get involved, the more you will learn. Stay scrubbed into complex procedures as much as possible. Sometimes general fellows will scrub out the longer procedures, but if you can, I would recommend you stay in, because especially people who are interested in doing interventional cardiology, you know, these procedures in terms of the actual technique, you can learn pretty fast. The harder part is all the decision making that goes in for those procedures. So if you could sit in with the interventional fellow and the attending as they discuss their overall plan for the patient, but even the back and forth at the table, like, should we use this, should we do that? You know, a lot of these 50-50 calls is where the true learning is, in the stuff that you'll have the most value in when you become an attending. Now, I recommend you work with as many different operators as possible, because everybody has little tips and tricks that they can pass on to you, and then you can incorporate the best of all of them into your personal toolbox when you become an attending. If you notice anything wrong or a missed step that you've read about or have seen before during the procedure, speak up. Like I said before, patient safety is the responsibility of everyone in the cath lab. So if you notice something, speak up, and speak up loud and clearly. No one should ever fault you for saying something. So every patient is someone's family member. Try to fight complacency and shortcuts during a procedure, and strive to always provide the highest caliber of care with each case. Here are some of the references I used for the procedure and for the talk. And good luck. I wish you guys the best. If anybody has any questions in regard to the talk, that's my email. I'd be happy to answer anything. And excited for you guys and starting your cardiology careers. Thank you.
Fantastic, excellent talk by Dr. Hoff here. Let's go back to our screen. So we have Dr. Hoff joining us, and so there definitely have been questions trickling in. We'll go ahead and launch off, and I know Dr. Hoff, you wanted to share your screen, so please feel free to do so. So the very first question was, how do you know when to choose radial versus femoral access? How do you decide? I think you're muted, Dr. Hoff.
No, it's a great question. Let me share one thing here first before we're getting into that question, because I wanted to show you guys the views of the right. So, you know, your RCA Common Views, this is in the left anterior oblique view, so the image intensifier is tilted over towards the left side. So this view is best for demonstrating the ostium of the right coronary artery, the middle portion of the right coronary artery, as well as the bifurcation of the right posterior lateral and right posterior descending artery. This is the AP cranial view, but also it looks similar to if you do a left anterior oblique cranial view. So the cranial views in general are good for laying out the distal circulation, including the distal RCA and the right posterior descending arteries, as well as the right posterior lateral. So interventions are looking in those lesion areas, you might have to go to a cranial view like this. And then lastly, a RAO, or right anterior oblique view, is with the image intensifier tilted over to the patient's right side. And this is good for, best for demonstrating the mid portion of the RCA and the extent of the right posterior descending artery. But as you can see, the ostium of the right coronary artery is not well visualized. The anatomy for the right coronary artery is much easier to learn than the left, because it's got that classic C shape like this. So if you see that, you know you're looking at the right coronary artery. Okay. So getting back to the question that was asked, so how do you choose between radial versus femoral? Let's see, how do I get rid of, let's see, stop sharing here. Okay. Okay, anyways. So in general, you want to try and go radial as much as possible, as opposed to femoral. For main reason is because it's more comfortable for the patients. You don't have to be bed rest for so many hours after the procedure. They can sit up immediately and eat. And there's less bleeding complications from the radial approach. So that's why most centers now, I mean, our center, we're 90, 95% radial approach for most cases. The times where you have to go femoral is when you have to do large bore access. So if you're placing impella, or if you're placing or doing TAVR, that definitely has to go femoral approach. And if you don't have a good radial access, so people who, for example, have end-stage renal disease and have a fistula or an old fistula on both upper extremities, so you can't really go radial, that'd be a reason to go femoral. Another reason you might go femoral is if a patient's coming in with a STEMI and it's a shock, like a cardiogenic shock STEMI case. So you know you're likely going to have to go place a ventricular assist device like an impella. You're kind of ready to go from the femoral approach. And then another reason you might want to go femoral over radial is if someone is a history of CABG and you don't know the anatomy, and so you have to do what's called kind of a fishing expedition to try and find all the grafts. That's much easier to do from the femoral approach. It's not impossible to do from the radial approach. Much easier to do from the left radial approach because traditionally we go right radial, but getting from the right radial up to the left subclavian and viewing the left intramemory artery graft can be challenging. It is possible, and many people do that. But if you go femoral, it's easy to get to all those spots. So that's kind of where you kind of tease it out. And if someone has a very small radial artery, if they have a significant radial artery loop that inhibits your ability to go from the radial approach, that'd be another reason to go femoral.
Fantastic. Excellent talk. And another question that we got is in regards to access. If I can't get access like the first time or I'm trying multiple times, how many times do I try before I switch to a different access, and what were your recommendations on that?
Yeah, that'll be up to your attending, honestly. I guarantee you're not going to be a one-stick wonder as an incoming first-year fellow. So, you want to try, and that's one of the reasons why, for example, let's say you've got radial artery set up and you put the ultrasound probe on. Let's say it was not a great pulse to begin with. You place that ultrasound on, it's a very tiny calcified radial artery. You may even stop then and be like, don't even attempt to access at that point. That's where you want to be. You call your attending over like, hey, can you come take a look at this? Do you think we should go ahead and switch immediately, or should we go ahead and attempt it? And he may even say, yeah, let's attempt it, but I might just go ahead and take over from the get-go because those really small arteries, if you miss once, a lot of times it spasms down, you can't even get it ever again. So I would say, it kind of depends on the attending. They might let you kind of struggle a little bit if they trust you, and they might give you a couple chances, but sometimes they give you one or two shots at it and like, okay, here, I'm going to step in. But anytime there's a question with the access, it goes with anything with the procedure. Let's say you're trying to get access, something just doesn't seem right, and you just have a question, always stop and ask for the attending to take a look.
So our third question, I think this is a great and very common question, especially for the person who's new to reading and looking at angiograms, is your LAD and your circ look very similar. And I think in the beginning, it's hard to differentiate. Can you tell them apart based off of where the camera is located, or are you looking at sort of just how the vessel looks? How do you differentiate the two when you're looking at the left?
Yeah, the answer is both, really. I mean, you get to the point, 100% agree. I mean, when I'm first looking at these angiograms, you're trying to memorize the anatomy as like, okay, what view? And then you try, okay, it doesn't come intuitive, but by the time you're done with training, it's going to be second nature. I mean, it's like, okay, that's obviously the circ, that's obviously the LAD. But yeah, when you're learning it, you want to learn, what view you're in, and that way you can anticipate where the artery is even going to be before you even take the picture. And so when you do take the picture and you look at it, you can tell, okay, that's the circ running down, and that's where the branch is. You're really memorizing what the anatomy is going to look like in a three-dimensional space, because this becomes especially important when you go to do bypass angiography. Because let's say you take the initial picture and you've got stump occlusion or CTO of both the prox LAD and circ, and even the RCA, and you're hanging on all by graphs, and the patient comes in, you don't have any prior anatomy, you're kind of going in blind, and you've got a couple of stumps, you've got one vein graft that kind of hooks to something, and that's where knowing where the vessel is going to lay out in a particular view helps you know where that vein graft is hooking up to. But also they do look differently. Like the LAD, you can see in a PowerPoint presentation, you can't really see it as well in terms of the projection, but you can see where the apex of the heart is. You can see kind of where things are laying out. And so the LED is going to course down to the apex of the heart to supply the anterior groove into the apex. And you can see the septal perforators coming off as well as diagonal branches, whereas the circumflex is, wrapping around into the AV groove. And so, learning what the anatomy is in that three-dimensional space is going to be helpful. And that just takes time and repetition, just like EKGs and echoes and anything else that you're learning, but it'll become intuitive with time.
I think one thing I did in the beginning of first year was if we're taking a caudal shot, meaning the camera's at your feet, and it's pointing up to the head, I know that the LED runs anterior. So whatever in your picture, the LED actually looks like it's above in a caudal view. Versus if your camera is cranial and shooting from your head and you're looking down, the LED actually looks like it's pointing downwards. So actually the caudal and the cranial, for me, at least, even now I sometimes use that to differentiate LED and CERC, but that could be a trick that you guys could use.
Yeah. And you'll learn with time too, because sometimes attendings pimp you, they'll cover up what view you're in, and say, describe the anatomy, what view are you in, and this and that. And so, that just takes time. In the cranial views, you'll have much more of the diaphragm that comes up in the shot. And so that's how you can tell if you're on a cranial view. And then in terms of REO, LEO, it has to do with the spine and where the catheter is in relation to the spine. And like I said, this will all just kind of come with repetition and taking a look.
Our next question has to do with radiation safety. A lot of our fellows are of reproductive age, and the question is, what is the danger of radiation to our reproductive health?
Yeah, no, I mean, radiation is bad for everything in the body, and that holds true to your reproductive health. And so that's where all that radiation safety comes into play. Your radiation dose every single month that you're in the cath lab is being monitored. And that's being monitored on top of your shielding. So the shielding, underneath it will be less, but that's why you don't want to cut corners when it comes to your shielding and what you're doing at the table as well. So ensuring that you have a good wraparound lead, because that gives you more coverage, and then sized appropriately where the lead comes down all the way to your knees. And so it's covering your, reproductive organs. And then also when you're at the table, usually the staff at our centers is really good at, making sure that the table shield is present. So, where the x-ray sources is under the table, and there's usually a lead shield that comes from the table and covers that area. So you even have lead protection even before it gets to your lead that you're wearing. And you really want to make sure that's not just there, but also in good position so that you're not getting hit by that. Because that's coming directly from the x-ray source, and that's in a sensitive area. So that's something when you walk up the table, you want to make sure that lead is there and you have good lead. And then in terms of you're at the table and monitoring what you're doing, tap on fluoro, only use cine for specific reasons, because that's where a lot more radiation comes from. And so like when you're doing an intervention, for example, anytime you can just kind of document by tapping on fluoro, that's going to be much better than cine in a lot of cases. Sometimes, you have to use cine obviously to get the information for specific reasons. But tapping fluoro when you're trying to move the table, don't just stay on fluoro and move the table around and fish around. You can tap on fluoro, and you'll get learning better. If a lot of centers the techs pan for you, but I think it's really useful. I'd highly recommend you learn how to pan yourself, honestly. Because you can set up the shots beforehand. You don't have to kind of tell them this and that, and so you can kind of tap on fluoro. Okay, no, I need to pan down to get the heart in there. And you can just tap instead of staying on fluoro. You can minimize a lot of radiation just by doing that.
So I think we have two more questions, and I think after that we'll probably end the session. So the next question is really about coronary engagement. So you had brought up earlier, don't shoot the dye unless you're engaged in the coronaries. How do you know you're engaged?
Yeah, that's a great question. You can tell. So basically, when the catheter is in the aorta, if it's not engaged, because you can see the heart beating, you can see the catheter and the heart beating separately. So the catheter will go up when the heart's beating like this. As soon as you get it engaged into the actual ostium, you're going to see it move together. So that's something that it's subtle and it's hard to notice when you're first in training, but pretty much once you get done with training, if you've done enough of these, it's like, okay, you're engaged, stop. And that's how the team always knows, right? They're like, okay, clock here, clock there, stop, because they know you're engaged without even having to test. And that limits the amount of contrast that you give the patient, which is important.
Fantastic. And our last question is, do you always perform an Allen's test prior to radial access? If not, when is it appropriate?
No, we always do. And it's usually either the fellow or a nurse practitioner or somebody, that should always be performed before you do radial artery access. And so, yeah, no, that's a great question.
Well, Dr. Hoff, thank you so much for the awesome talk and also taking the time to do this live Q&A, answering our questions. I think this is definitely a topic that brings on anxiety for first-year fellows. So really appreciate your time.
Yes, fantastic talk and a very important topic that we all deal with.
And thank you for setting this up. I think this is a great resource for incoming fellows. So you guys have done an excellent job. If you notice in my talk, I didn't cover hemodynamics. The reason why is because, to give a 30 to 45 minute talk and cover all this, I feel like including like one slide on hemodynamics would have just done a horrible disservice. That's at least one talk, if not multiple, to cover that. So
no worries, we'll have hemodynamics and other talks, so not to worry. This session is recorded, so if anyone wants to review it again, or even for those who can join us live, we'll have it posted and available. And next week we have Dr. Velasquez from Harbor UCLA, who's going to be talking to us about syncope. So thanks everyone for tuning in. Thank you, Dr. Hoff. And I hope you guys have a good night. We'll see you guys next week on Wednesday.
See y'all soon.